How many of you approach a patient and say, this patient definitely has an afferent input problem? Does that sound ridiculous? Maybe it makes it sound like I'm making PT more complicated than it is, but I don't think so. I think in those terms all the time. You see, there's this good chance that some of your patients aren't getting well enough because you aren't thinking in those terms. And if you saw our last pain video, the reason they keep ending up in that sort of wavy between pain, pain-free pattern could be that afferent issue. To help highlight this idea, we're going to talk about the dramatically named Manual Therapy Lesion model. And this, I believe, comes from Ola Grimsby and Jim Rivard, since I first heard about it from their wonderful science theory and clinical application textbooks. The first step in the model is collagen trauma. This can be any type of damage. We're talking about repetitive injury, trauma, immobilized tissue, surgical intervention, all of the above. The first step is that you're getting some sort of tissue damage. And understand this could be micro damage. It could be that you're just doing a wee bit of damage to the tissue and it's breaking down and it doesn't give you any pain whatsoever. But what the result of this is receptor damage. Now, all that tissue you have in and around the joints in particular is dense with receptors. These receptors, they have a lot of jobs. They let you know about pain, they let you know about position sense of the body, they have reactionary reflexes in order to keep the role or the right amount of tone in your muscles during activities to protect you. And if these get damaged, well, the result could be that now you have reduced muscle fiber recruitment. There are a lot of automatic responses in the body. We have a ton of relays in place that are there to have automatic response of the muscles helping us out. Just think about if we had to think about every muscle in our body and concentrate to make every muscle do its job, we'd be completely overwhelmed. Or we just want to sit around all day and do nothing because the act of movement would just be so taxing. So we have these automatic responses. So we might now have muscles that the fiber recruitment diminishes. And that means that the muscle isn't turning on and off again because the receptor's not there, which could lead to tonic fiber atrophy, aka the muscle gets weaker. You use it or you lose it. And a tonic muscle not getting recruited is going to start to get weaker. And what is the role of a tonic muscle? Well, postural. They keep us upright. They help keep us nice and stable, specifically around the joints. You can tell when a tonic muscle gets weak because what does it do? Well, we'll come back to that. What about a phasic muscle? So if you're doing bicep curls and the muscle fatigues, your arm just kind of drops. Phasic muscles just kind of quit. You can't keep doing it. But if our anti-gravity stability muscles did this when they got fatigued, we'd just be puddles of skin and bones on the floor. So instead, when they get fatigued, they lock up and they guard. Mainly, the result of this is that now we're going to have motion around a non-physiological axis. This sounds so technical, but I like to think of it as that like a loose tire on a car. If you're driving around and the lug nuts aren't on tight enough, it's going to start to wear on the tire and the axle more. It means that you're doing damage. Or if you have a ceiling fan that doesn't have snug blades, what starts to happen? You get that wobble of the fan, you get the noise going, the whole thing shaking. I mean, do you think that's good for the fan? Probably not. Probably going to lead to damage, and that's what it does. It leads to trauma or acute locking, degeneration, etc. So now we get the real damage. Odds are this is when the patient actually first feels or thinks about this as an issue. Prior to this, they didn't really have pain, most likely, and just kept going about their daily business. Now, pain is an issue, which leads to pain guarding. And now all the fun begins. These are all our patients typically when they walk in. Some sort of tissue damage and some sort of pain guarding loop that's increasing the damage, increasing the guarding, etc. And so we have an issue. Why do I like this model? What is it about the very serious sounding manual therapy lesion that I enjoy? I was always told during my residency that where therapy mainly lives is in the realm of motor controlled dosing. And yes, strength, endurance, power, they're all very important, but every patient is going to need motor control training. And this model highlights the fact that it was a breakdown in the afferent input into their system that resulted in a cascade of events leading up to tissue damage. So if you don't reestablish the link of afferent input, then you might not get what you want. This highlights to me the concept of assess, treat, reassess, and how a lot of times when a patient is having pain, the first thing I try and do is add afferent input into the system to see if it can slightly self-correct. External cues, palpation, all of those things are going to add afferent input. If you've seen the past video on the RAMS model, for me, the retraining of the RAMS model, I really look at the afferent input of that area. So go out there and fix some manual therapy lesions. Make sure you are highlighting afferent input. And if you enjoyed this video, hit the subscribe button and notification bell. I'll see you next time.